webinar should be short and center on a specific pathology or procedure. And this evening, we have chosen to make this a state-of-the-art on the so-called ontoplasty. For this, I asked two experts and friends to present their experience and tips. Wiebke Hulsemann, who is the heir of Rolf Abenicht and Dieter Bungramko from the William Schiff Katholische Hospital in Hamburg, and Steven Ovius, formerly the head of the plastic surgery department of the Erasmus University of Rotterdam. He's retired but still very active, leading a lot of PhD theses and still operating both on adults and children. There will be two parts on the seminar. Firstly, we will talk alternatively on the principle and the thumb reconstruction with the ontoplasty. Secondly, after a very short discussion between us, we will focus on the other digits and how we can push the limits in the reconstruction. Then we will open a discussion for at least 15 minutes. Alain Gilbert, our mentor and founder of the Institut de la Main, will join us with his huge experience of microsurgery. So please feel free to send your question to the panel through the chat and please answer the poll. So now, without further ado, I give the words to Wiebke Hulsemann.
Yeah, hello, good evening, and thank you for the invitation. Ontoplasty, when I was thinking after Stéphane's invitation what might be ontoplasty, I choose this interpretation. For me, ontoplasty is a transposition of an entire finger stump on its neurovascular pedicle onto another distally deficient finger at phalangeal level. That's not, for example, a non-vascularized finger or toed phalanx transfer for stabilization. And when I went through our patients, I found very few patients in whom we performed ontoplasty on phalangeal level. In the last 25 years, only 11 patients and with 14 hands I could find in our register. Maybe that's a little bit due to the lack of register, but I think it's not so often performed. Indications in our patients were thumb duplication. We start with that now. Ulnar polydactyly 3, hypoplastic distal phalanges of other fingers 4, and partial thumb aplasia or short thumb in 5 hands. On metacarpal level, we perform it much more frequently. First example, thumb duplication. That's a typical indication for these. Normally, the ulnar thumb is the better one and the radial is resected. In this case, the proximal part of the radial thumb is very good developed and the distal part of the ulnar one. So this is, for me, an ideal indication for transposition of the better distal ulnar one onto the radial. The arrow has to be in another direction. No? Also this is the radial one, the better developed radial one, and the ulnar was pushed, transposed to the radial side at proximal phalanx level. That is intraoperatively after resection of the bone of the radial one, and this is after the transposition before closure, and that is after skin closure. In this child, the first web was of good width, and so we had nothing to do to widen the first web. And that's the result 5 years post-op, a good shape, and the arrow again is indicating the level of transposition, and she can write easily with this hand. Next example, we operated him recently, 1 year old. It's a little bit different to the former double thumb. Both thumbs are lying side by side, and also here, the proximal part of the radial one is better developed than that of the ulnar one. And again, transposition of the ulnar one onto the radial proximal phalanx. And the incisions are zigzag. because also he has a very good width, so we have nothing to do with for widening of the first rep. Yeah, these are my two cases.
Thank you, Wiebke. And now, Stephen, you have also experienced this reconstruction on the thumb.
Okay, thank you very much. Thank you for giving me the opportunity, Stéphane. And this is our congenital hand group, and we're here in Cambodia after we were hosted by Stéphane in Vietnam, which was a great opportunity, by the way. And here's the CHAS group doing only congenital. If you think about ontoplasty, when Stéphane asked me to do this, I was thinking actually of the history, and it's mostly written in the trauma cases. This is Esser. Esser was a Dutch surgeon who worked in the First World War, and he did it like Nicola Doni also did things like that, like giving pedicle new hands by putting the foot to the hand and having a result like this. I also have a picture of this guy gardening, and so he was able to do that. I won't say anything about function because I haven't met him yet. If you look at history of the ontoplasty, then one guy should be mentioned. That's Gillies after the Second World War, and he made popular lengthening of the thumb by using an on-top graft, as you can see here, and putting in a graft here, and using the remnant of the thumb coverage to hide the bone graft in. And that is the real ontoplasty. But we're not talking here about trauma. We're talking here about congenital cases. Both Wiebke and I are used to do that. And first of all, non-vascularized. In the earlier days, it was, especially in symbrachydactyly, which this is a case of, it was custom to put in a non-vascularized phalanx transfer with a growth plate so the phalanxes could grow. I hate this operation because it's unpredictable and because you never know if it's going to grow yes or no. And 3 years is far too old and give less results than if you have a 1-year-old. But here you can see the guy after 7 years, and here you can see the phalanx transfer, and here also. Here we had to arthrodese the thumb because it was floppy, but had grown, but not as good as the small finger, if you like. It did give him a better grip, as you can see here. And here you see him with his type diploma, and I know he can do much better than I can. So that's for sure. That was non-vascularized. I don't have many non-vascularized cases because, as I told you, I didn't like it. And when I started, it was in the era of doing more vascularized stuff than non-vascularized. And by the way, you also have bad feet. Now, for instance, if you look at this constriction ring syndrome, you cannot recognize a real thumb. Something with the index and the middle finger and with a sort of thumb is down there. And right in the middle of the palm of the hand, you see the constriction. And what we did here is we used, as you can see below, on the below left, you can see we used something of an index as a pedicled flap to put on top of that thumb remnant. You can see the picture drawn. And this is a possibility. Is it the best possibility? In retrospect, I don't think so. Why not? Because the thumb tip is not as good for cold intolerance and things like that. So I would rather use a free tissue transfer here, like a toe to thumb, instead of doing this. But it is an option to do a thumb reconstruction in this way. And you can see that you can do it. But I don't like it, especially not in cold countries where you might have cold intolerance and it's not helpful. And then they only start to use this part and not that part of the thumb. Although you can have very nice pictures, as you can see here. This is a case which is exactly the same as just a little bit different than Wiebke has shown. And as Wiebke, and because we have compared our both series together after a huge amount, and also we have hardly any of these cases. And most of them are just hypoplastic on one side or are diamond shaped, but you do have these. And as in the Wipke's, but here's a flexion contracture. So this thumb can move, but it's not useful because of his extreme flexion. And this is a nice and good, well-vascularized in-between finger, if you like, or thumb, and we put it on top of that. As you can see here, it is complete. You have to take care that you don't get the traction too much. You can see the vessels here, because if you have it too much, you'll get a bad finger or a cold intolerant finger or a finger which gets epidermolysis or even worse. I haven't seen that, luckily enough. I'd rather take something off of this bone than have a bad vascularization of that distal part. And here the long 8 years follow-up, you can see it's a very useful thumb with, and as the same as in the case of Wipke, no web reconstruction other than closure after transposition of this thumb part. And you can see here the X-ray of the thumb. I'm sorry, I'm using my mouse, but I realize you can't see it. Going on to triphalangeal thumb, as you can see here, it's always funny if you look at these pictures, because you can see a hand with a lot of fingers actually, but the most radial one does look like a thumb, and the next to the radial one, yeah, what is it? Is it a finger or is it a thumb? It's mostly a combination of both, because you can see something of tenar, but you can also see two flexors sometimes, and it does look like a finger in this particular case. You can also see distal and proximal growth plates, or even both. So all the variations are there. And these children have long first metacarpals. And what we did here, as you can see at the bottom line, that we have a transposition of the ulnar thumb to the radial position. And now we're coming to a remark I make. Mostly the radial CMC joint is not as well preserved as the ulnar CMC joint of the thumb. So I would, in retrospect, rather use the ulnar CMC joint instead of transposing the whole thumb to the radial CMC joint. And I've seen a couple of cases, and I've totally abandoned that. So here you can see the case. You can see it's on the radial side here, radial side there. And the thumb is absolutely useful, but I'm not in favor, in the end, by comparing our policizations in these kind of hands with the reduction and abduction osteotomies, and those were better and looked more actually like a real thumb. And I will show you that here. This is the case of a triplication, where you can see that you have extra, and the green arrow points at the third thumb part with a short middle phalanx and an extra distal phalanx which is fused. And you can see at the broad thumb on the left that is more double there. It's an important part, by the way, because I will tell you that later. And here, what we did here is remove the radial side and did a rotation, reduction, abduction, osteotomy of the ulnar thumb, and we did also a thinning of the distal part of the thumb on the ulnar side. And the intrinsics were also repositioned. And here you see it 1 year post-op and 6 year post-op. But if you look closely, you can see the nails are a little bit deformed. So you have to take care with the DIP arthrodesis. It's a DIP in a thumb. Sounds strange, but it is. That you do not damage the nail plate. And as you can see, so my preferred operation in these kind of hands is to do a shortening of the first metacarpal, because they're always longer, do an abduction and rotation, and do a DIP arthrodesis, so you get an IP on sort of the normal range, if you like. So no policization is my tip there. We go on. I don't know if you can call this an ontoplasty, actually. I'm not sure. But basically, on this whole webinar, we're not talking about real ontoplasty, because there are a few ontoplasties, like Wipke has shown in her polydactyly cases. And if you look at the politicization, it's also a sort of shifting and transposition on its own base, but in a different way. And it's in that sense, it's on top. But you can argue if this is really on top. In the left side, there was 30% less strength. Why was that? Because they were actually quite similar. But you can see at the elbow on the left side is quite different than the elbow on the right side. And there was also a pro and supination difference, and having therefore more difficulties on the left side than on the right side. And you can also see how important it is in the thumb ray to really damage the growth plate at the proximal base, because otherwise the thumb gets longer, as you can see it on the right side compared to the left side. And here with 8 years follow-up. And then for the constriction ring syndrome, I think the only way to reconstruct this is doing a vascularized free transfer. As you can see here, after 4 years, the toe transfer to the thumb site, you see that the toes are not normal. Here's a shortened toe. Here's also a bit different than the other toes, but it is well preserved and it has a good growth. And I think this is the best option for these kind of cases. And this is the last one, just to show you that toe transfers in these cases are the best option. But I also want to show you that you can have complications. Here's a good toe transfer, and here it was skin loss, and we did a flap on it. So it's less mobile than that one. So you have to deal with your complications also. So in summary, know your pathoanatomy and your pathoembryology. A reconstructed thumb is never as strong as normal, and we compare it to the other side, but that's not fair because the other side is mostly also affected. You should compare it to normative data of normal children. Non-vascularized bone grafts depend too much on the surrounding tissue, therefore unreliable. But pedicle composite grafts can achieve good function and appearance. But free toes are never like a real thumb, but it's the best we can offer in specific cases. It has sensation, it grows, and it has some motion, but not normal motion. Don't believe anything I say. Test it yourself. Thank you very much.
Thank you, Stephen. So, Stephen, you have shown all the possibilities to reconstruct the thumb. I will come back to the ontoplasty. And first of all, the name ontoplasty. The first man who used ontoplasty was a Norwegian man, Henrik Søyland. He published in 1961 a paper. It was for trauma cases. And then the team of Kelleher gave the name, recoined the name ontoplasty mostly for trauma cases and one case for constriction ring syndrome. So this is maybe the story of the name. Then it has been also called the spare part surgery. It means that nothing should be thrown away in a congenital hand. So if we can use some parts, some bones, or all a fingertip, for example, it could be useful for lengthening and also to give more cosmetic appearance on the fingertip. We have many indications for the thumb duplications, but you will see that they are not the usual thumb duplication. Some triplication with or without triphalangeal thumbs, some ulnar cleft, we will see in the second part, constriction ring syndrome we mentioned, complex polydactyly and trauma cases. So I want also to mention a very important paper that I have seen it's a French team from Bordeaux, and they shown that you can sometimes lengthen a stump with an adjacent digit and keeping the arterial network by ligaturing the artery just before the division in two proper digital arteries, and then you can switch the donor stump. So this is a useful tip if you want to lengthen and keep the arterial network. Now, there are some indication on toes, but I will not take a long time on this, because in this indication, with mostly a duplication on the fourth digit, who is linked to the fifth, I usually remove the lateral part of the fourth digit and open the web. But in this case, they have transposed the bones. So it's not the common indication in this toe duplication. Yeah, sorry, I want to focus on the thumb. These cases are not some true thumb duplication. For me, thumb duplication is a unilateral presentation. It's not by no inheritance. And clearly in the vessel 1 to 6, it's probably a cleft end, but just on the radial side. That's why you have two thumbs, a single thumb is divided in two. So it's probably different from this presentation, where real preaxial polydactyly were usually bilateral and have really strong inheritance. So in these cases, we have to deal with the different parts of this abnormal thumbs, and mainly the ulnar part is floating with no metacarpal bones. So in this case, we can transpose the best fingertip on the ulnar component to the radial side. And we will hope to have a more cosmetic thumb. In this case, for example, I have done this, removed the distal part of the radial thumb and transposed the ulnar part to have a very good tip. But the main problem could be the tendon transposition, and I would like to discuss on this. Do you cut the tendon, or do you still leave the tendon in continuity? That's a very important technical pearl. There is a paper who is not published yet, it's just online, but it was interesting to see what they have proposed to avoid a circular scar in the dorsum of the radial thumb, and they keep part of the skin of the lateral part of the radial thumb. So it's a very interesting paper. It will be published soon. And, you know, we will discuss on the incision, but usually a circular incision is quite very, very discreet, and usually it's not a problem. This is a case operated in Brussels with Jean Goubeau. This child had the same problem with always this floating ulnar thumb, but a very stiff and deviated radial thumb. So these are the incision I used, and with the most important part of this dissection and the division is to harvest the venous drainage and check that you have at least two very good veins to be sure that you can transpose safely the finger. And usually you're not obliged to go too close to the veins itself, but keep them in surrounded by the fat tissue to avoid any damage. And then the arterial dissection for people who are trained with microsurgery is really easy. We have sometimes to divide the arteries and make a ligature for the proper digital artery for the index finger to help for the transposition. Then we can cut the phalanx at the level we have chosen and check that the transposition is easy without any tension, and then make an osteosynthesis, usually with the care wire, but some people maybe will use a different device, maybe some, I've seen some iron stitches. This is the final result, and usually we have a really good reconstruction, and the very important goal for the cosmetic is to have a social acceptance. So that's why this procedure is really both cosmetic and, I mean, really functional. There is an interesting paper also by the team of the Texas Scottish Rite Hospital in Dallas, and they have reviewed all their patients, and they mention that the IP joint is usually stiff because the flexor pollicis longus is not really functional, but the MP joint usually is good, stable, and the overall function is good. And the Chinese paper I shown with the drawing had also some very good function. This is another case with more unusual because there was a Y-shaped first metacarpal bone, so I had really to make a carving in the first metacarpal bone and to create a new first metacarpal and then transpose the ulnar part on the radial base. And the function was also very acceptable, and the appearance also is very natural. And this is a very tricky one, was clearly family inheritance, because it's what we call the sympolydactyly triphalangeal thumb. We know where is a mutation on the zone of control of the sonic hedgehog gene. It's not the sonic hedgehog gene which is mutated, but these families have usually some very complex syndactyly with some triphalangeal thumb and some triplication or even tetraplication, and like on this child on the right hand. So I operated this child in Vietnam, and I've done simplification on the left thumb first. I removed the radial thumb. I was so impressed with the result of the left thumb, and the family was really happy when I have simplified the thumb, and is very functional. And now we have operated on the right thumb, who had 4 thumbs in one, and is a little thicker, but still very good. So I have stopped with this presentation. Now we can discuss just a little. I have few questions for you, Wiebke.
Yeah.
In your cases, I was impressed because you have no circular incision. You were able to.
Yeah, because of the good width of the first web, there was no necessity to go into the first web. And therefore, it was enough to have these dorsal and radial zigzag incisions.
Yeah.
But that might be different. That is different if the first web is very narrowed. Then I would use a rotation advancement flap and go into that.
Okay.
You were lucky with these 2 cases.
Yeah. Because they looks nice without any dorsal scar, which is the social part of the hand, and it's very important. And for Stephen, first, how do you make the synthesis between the bones? With the K-wires or with some?
It depends on the age.
Yeah.
If you're young, we can either use a very thin circulage wire, or use even a vicryl stitch if you want on both sides, or make a box circulage wire. And I tend to go away from K-wires. It can give problems later on. I try to avoid it, but if they're older, I use K-wires also next to circulage wires.
Okay.
But
what about the CMC joint? You said, because you mentioned that you will not try to reconstruct a CMC joint. You prefer to keep the normal one, yes? Yeah.
Then the normal one is, by the way, not normal. It is less mobile than a normal CMC1 joint, but it's much stronger. If you look at our cases, we've published that. If you look at our cases of the polycizations, which have, to my mind, an unstable CMC joint, if you like. It's not a CMC joint, but something like it. And if you use a shortening osteotomy and palmar abduction and rotation, then you keep the strength of the CMC joint. It's not as mobile, but it does, and the appearance is also better because you shorten the metacarpal. The first metacarpal is extremely long in the triphalangeal thumbs. So you cannot reconstruct it only by using a shortening at the finger. You should also do it at the metacarpal.
Maybe we are a little bit out of topic, but the CMC joint is always very crucial point, and
Yeah.
yeah, it's the same for I've seen many mirror hands now, 5, and my best results were when I kept this true CMC joint on the most radial digit and transpose one ray on the radial base. That's
So you're
probably
basically saying the same. Yeah.
and
The only
probably.
thing, the
Yeah,
only thing
sorry.
to take care of with the radial CMC joint is they're often hypoplastic, more hypoplastic than the ulnar one.
And Stéphane, how do you choose when you have 6 metacarpals? No? When you resect the radial one, you look before the operation, your X-ray and how big the CMC joint is. Is that your indication for resecting the whole radial one? Or do you look intraoperatively and look which of the both are the more stable one?
We are far away from the ontoplasty, but if of course the first CMC was very hypoplastic, I wouldn't recommend to keep it.
Of course.
And you clearly see it on the X-ray. So usually I decide before surgery which the CMC I will keep. But anyway, it's not the real problem of the CMC. For the constriction ring, also, I do agree with Stephen that I have experienced to reconstruct a thumb with the stump of an index, and the result was really awkward. It was too long because I had 4 physical plates, so I had overgrowth. I had to perform epiphysiodesis. And finally, I do realize that the best indication is a free toe transfer on the stump of the thumb. Clearly, it will be my choice, and never try to do this mismatch with the fingers on the constriction.
I will show you some case in which I have done it. But
yeah, we always can. Always some parents will refuse to harvest the toe. That's a cultural problem sometimes, and we have to respect the decision. But of course, so we can keep on and go to the second part of the meeting, and then we will discuss with the audience. So, can you launch your second presentation, Wiebke?
I do.
We will focus on different cases, the most complex, and how we can push the limit with this pedicled ontoplasty.
Yeah. Now we talk about ontoplasties in the central part of the hand and at the ulnar side. I start with the duplication of the small finger. This is a triplication, as you can see, but it's an old case treated in the 90s by Bogramko and Habenich together. And here are some details. This hypoplastic one, third is resected. And the radial side of the little small finger, they transposed onto the base of the middle phalanx. The green line indicates the formation of the joint space, and the orange one in the next X-ray indicates narrowing of the head of the proximal phalanx. And then we transpose the radial one to the ulnar one. And please excuse the old, odd X-rays, they are old. And that's the girl 15 years later. It's a medium result, I think. The pip joint healed in spontaneous ankylosis. Other case we operated recently, also with a tripled small finger. And at the left side, it was this tripled small finger. At the right side, all 4 extremities were affected. At the right side, the spinodactyly with the floating small finger, and the feet showed polysyndactyly with a metatarsal synosdosis. And transposition or ontoplasty we performed on the left side. Here, in green color, I show the resected parts. It's a common MCP joint, and we left this straight middle portion resected the hypoplastic radial metacarpal and transposed the ulnar small finger onto the base of the radial proximal phalanx. And that's she 3 months post-op. The parents sent me this photo because we operated him recently. An old case, also some 20 years ago. It's an example. It's a Werner syndrome, a very rare hereditary disease. It's a kind of excessive polysyndactyly. Typically, both hands are cup-shaped, and the distal parts are duplicated. Here, the small finger, and the feet are affected as well. And Werner syndrome is characterized by a partial tibial aplasia. And here, to the ulnar the distal part of the ulnar small finger was better developed with a better nail anlage than the radial one, and so it was transposed. And the X-rays and the photo in the middle and the right side shows the patient, the girl, 14 years later. So it's a small remnant distally. And now constriction band syndrome, other indication. It's a baby of a Congolese mother, and both hands had partial thumb aplasia, we talked just now before. And the other fingers here, second, on the left hand, second to fourth, is as an acrosyndactyly, also at the right side, better developed because the index is better. And this is she, her both hands at the age of 5 after the first web space creations, deepening of the webs. Of course, without thumbs on both sides, you can grasp the glass only taking both hands, with both hands, but her feet were also affected. So I think I'm convinced that a free toe to hand transfer is the best solution for constructing of the thumb, but because of these feet, we have to choose another treatment, and that is transfer of a pedicled other finger. I choose the worst finger, that is the ring finger, and transpose it onto the remnant of the proximal phalanx of the thumb, together with a widening of the first web by rotational advancement flap. This is the photo is 10 days after operation. And for narrowing of the hand, I resected the whole fourth ray, also proximally. And that is she 2 years later. She can grasp in glass and has a good mobility and has a good writing. So it's a possibility. Her left hand is uglier, awkward, I think, but also here I've seen the only possibility to create a longer thumb by transposing the distal part of the index remnant, that is the distal part of the second metacarpal with the base of the proximal phalanx onto the first metacarpal. And that she, some 2 years later, she can hold this cylinder of 5 centimeters diameter and this pencil. Yeah, the cosmesis is not nice. And a last example, a very rare disease, 9 months old girl with a brachydactyly polydactyly syndrome caused by a COX-13 gene deletion. She had, pardon?
Yes, OD13, yes, sorry.
Yeah, she has this syndactyly of finger 2 to 5 and two rays on the thumb side, a very short one and a longer one. And when you look on her X-rays and also those of the feet, the skeleton is totally irregular constructed. In the hand at metacarpal level and also at the phalangeal level, in hands and in the feet. And to create a better thumb, a longer thumb, we transposed the second ray from the radial side onto the remnant of the short radial ray, on the remnant of the proximal phalanx of this radial ray. This is the right and two teams simultaneously, right side, left side. And because I did it recently, I have these photos 6 weeks post-op. Cosmesis has improved, but it's too early to evaluate function. Function may also depend on the intrinsic muscles, if they exist, and the mobility of the other finger. And this is no malformation. This is my team, and I have to send you greetings to the audience and to you both from them. Yeah.
Thank you, Wibke.
You're
Good
welcome.
job. And Stephen, how will you push the limits?
I don't know if I will push limits, but at least we'll try. We haven't talked about central polydactyly yet, and this is actually a rare case of central polydactyly, because you mostly see the hidden polydactyly with syndactyly. But here is in fact is what is this? Is it a transposition? Is it putting on top of another metacarpal? You can call it what you want. Anyway, we dissected this ray out, and we did a osteotomy like this and this and this, and so take that one out and then transpose the finger to the other side. As you can see here, the sort of the bifid following of the extensor side and of the flexor side, and here the osteotomy is trying to mimic this kind of osteotomy, and two circular wires there. And by this, basically it's a ray amputation, but it's a more difficult ray amputation because of the bifid. Otherwise, if you won't do that correction here, you will grow in a deviated manner. These are more complex cases, and I've never seen cases like this with a good outcome, a real good outcome. I mean, in terms of a good fist and in terms of nice fingers with normal length. And you can see here, it looks like a jungle of bones, and polydactyly with syndactyly, and it was, as I've shown here, it was heredited. It's his father. And here is the first operation, trying to create the fingers and trying to make as much of it as possible. And then he had still, in the second operation, a rather thick part here at the forefinger. And here we removed that and trying to make it less. But you can see here in his fist, he still has this finger, which is rather stiff. But the other fingers do well. So the grip is all right, but it's not a perfect result for a hand like this. And here you can see also the aberrant growth plate on the other hand. These are difficult cases to my mind, and difficult to get a real good extension flexion at the end. You can call this also a central polydactyly if you like, or you can call it a thin polydactyly. Sometimes it's difficult to realize which it is. This is at 1 year old, same like the other case. It's a jungle of bones with which you have to take care of the aberrant growth plate here, because you then know you will get deviated. Now, I showed you this first just to think, what would you do here? And maybe this is nice for a discussion, but we don't have the time for that in terms of what the expert panel would do, or somebody from the audience. Anyway, as we said, pushing the limit. You can see here it's a bit of a mess here with all flexor tendons, and you can see here a pedicled fingertip trying to transpose it to a more normal position. And what you basically have in the end is two stiff fingers, as you can see here, with good ulnar fingers and a good thumb, and here with joints which are there, but not in a good movement, because you don't see any creases in the index, and you see only a little bit of crease in the third finger. This was a mind-boggling one, because this had also bad feet, and as we all know, these are little slits which go down to the palm of the hand, and the rest is all a real acrosyndactyly, which is normal for these kind of cases. The point I'm making here is where do you make your decisions, where do you make your incisions, and how do you decide what goes to one side and what goes to the other side? Because it's unrecognizable. This part is a complex of 4 distal fingers. And so which one is going to that side, which one is going to that side? And it's often just following the lines of the interdigital spaces and hoping that you can get it right. The same happens with Eipert syndromes, as already a little bit not really mentioned by Wibke, but a similar case. I like to make a plea for Rolf Habenicht, who did the constriction rings like this instead of doing big C-flaps. He told me to take out the whole inner constriction and go right down circular. And the first time you do this, you think, oh my God, but it works very well. At least I've seen it working very well. Now here's, yeah, this is the case with the same case with further desyndactylization of the digits here. You've seen the other side. He has a good grip with his left hand. His right hand is still quite difficult to get it right. And toe transfers were not possible because of the feet. You could argue here to do more like transposing, but I thought if you look at this hand, it functions well. So I left it like it is. I like this case because you don't often probably, Stéphane, I know he does a lot of clefts, has seen it often, but most clefts I see are not this deep as this particular case, with also synostosis here on the ulnar side. And what we did here, actually, think about what you would like to do, but you can see at the incision what really has been done. It's like a transposition on top of the carpal bone, the proximal carpal bone, which you cannot recognize, but it's there, but it's more cartilage-like, if you know what I mean, and because of the age, and doing here Barsky kind of flap, and here a foreflap. And you can get in this sense in here doing a wedge out and transposing the whole ulnar part to the right side in the carpus, and also releasing the fusion of the 4th and 5th metacarpal. The last one, I know it's out of line for ontoplasty, but basically it's the whole wrist putting on the end of the distal part of the ulna. It's an ontoplasty, if you like. It's a vascularized hand on top of the distal end of the ulna. This is just for closure, for fun, and because I like to stretch the term ontoplasty, if you like. Yeah. Here is as a baby, bilateral type 3 and type 4, and here is at the time of operation, and here after pollicization and stabilization of the wrist. First stabilization and then pollicization, and then bilateral ulnar lengthening at 12 years with 7 and 9 centimeters on one and on the other side. And he's this guy who can do this kind of stuff, and I can tell you, with my both hands, I can't. Merci beaucoup.
Thank you, Stephen. So you pushed the limit of the name ontoplasty very, very far. So I give my second presentation very shortly, then we have many questions. So push the limits, I want just to show some examples. For the fingertip reconstruction, sometimes we can harvest a good pulp, for example, on the ulnar side of this digit, and transpose it very easily. There are many questions about the nerves and the blood supply. Usually it's very easy to divide and to make then the transposition and osteosynthesis. So these are very funny and very easy examples, but it really helps the children to improve the overall appearance of the hand. And this is the result, a long-term result. The joint is good at the MCP and PIP level, but not on the DIP. It was very stiff, of course. This is the most complex child we had. It's a split hand foot malformation, type 7. It means she has a mutation on BHL HN9. It's now well documented So the child had, you see this very deep cleft on the left foot, a complete synostosis between the radius and the humerus on the right side, but the right hand was normal, fortunately. But the left hand had this very strange appearance with this floating finger just linked to the fourth ray, with an absence, complete absence of the fingertip on the fifth, who was also very ulnarly deviated. But we discussed with the parents, they say, can you remove this floating finger? I say, yes, but if you want, I can maybe try to transpose it. And, you know, it was a funny micro dissection. And with this very, very little vascular bundle, I was able to transpose it and make the bone fusion. And this is the final result. Of course, it gives a quite better appearance to the hand, and we still have a lot of work to do, probably osteotomy on the fifth metacarpal to have a better alignment, and also the syndactyly release. But now the finger is have a very good sensory recovery and a very better appearance. So to conclude with this, it's clearly not a non-standardized procedure. The imagination of the surgeon is very important. It's a creative use of the spare parts, and we want to keep the best of the abnormal fingers and try to have the best finger as possible. Of course, it requires a good background in microsurgery, but it can really improve the function, and because of the length, and also the cosmetics of the hand, and it's very important for the social life of the children. So we are finished with the presentation, but we have many questions. First, some people said, when we transpose and we want mainly on the constriction ring syndrome, what about the nerves? Can you answer for this, Stephen and Wiebke?
Oh, sorry, you repeated. I was just looking to the chat. I was a little bit distracted. Again?
Sure. What about the nerves? Do you have any problems when you transpose?
No.
No?
No. Also in the constriction band syndrome with transposing the ring finger, there I cut the nerve and sutured it again.
Okay.
I made a nerve anastomosis, but in the other cases, it was no problem to transpose the nerve together with the artery to the new finger.
Okay. What about you, Stephen? Did you have to make microsuture on nerves? Or?
No, mostly not. But mostly in these little things, there's only one pedicle which is all right, and the other one is you cannot even see it. So thin it is, or it is not. So if it's one neurovascular bundle, you mostly prepare the whole bundle as such, and you mostly don't have to divide the nerve. And if you do, you can dissect it out in the common digital or more proximal. So mostly not. But if you, we all know that in children nerve coaptations do quite well, but there is a but. That if you look at it very well later on, it is different than the normal finger.
Stéphane?
Yeah.
May I ask you, for your last case with this ulnar cleft, did you perform an arterial and venous anastomosis?
No.
End to end? No?
No. Just follow the pedicle, the vascular bundle, and including the nerve.
Pedicle. Yeah.
Yes, and I was lucky that the division was proximal and not too distal. So I was able the fifth and put the tip on it. But of course, it was very challenging, but quite happy with the result.
Yeah, so, it looks nice.
So that's what we call push the limit. I hope this seminar, webinar, will give some indication to the audience. Some people ask, for example, in case of volar injuries in trauma cases, can we trust on the dorsal neurovascular pedicle for ontoplasty? I wouldn't recommend this.
Yeah.
Well,
Yeah.
in the thumb, we have, of course, the princeps pollicis, where the volar thumb arteries can be divided completely, and the thumb is still very nicely, if it's more distal to the bifurcation from the deep palmar arch to the princeps pollicis, then you don't have to worry about circulation, which is odd actually, because you see both volar arteries being cut, and but that's the case if you have that kind of princeps pollicis. So that's for the thumb, it could be no problem. If it's very distal, you can trust on dorsal circulation. If it's more proximal, and by distal I mean distal from the mid-phalanx, if you go more proximal, then your anastomosis is less reliable because you have a longer pedicle to be vascularized. At least in my hands.
And they said, simple question I mean is, what is optimal age for reconstruction on a radial polydactyly, preaxial polydactyly? What is your
1 year, 1 year, 1.5 in the second year of life.
Yeah.
I think it depends very much on, at least we all know that anesthesia is not so nice for under 1 year. So if you can postpone it to over a year, I would always like to do that. I only think there are few indications to go below 1 year. That's in radial polydactyly very, very rare. The only thing you might take care of, that if you have a very difficult polydactyly with syndactyly, that you take care that you that you don't get growth problems if you wait too long. For the rest,
I will recommend just between 1 year and 18 months. That's the average for this procedure.
2 years, and maybe you should say, why not 3 years? Because in the age 2 to 4, you tend to be very much in your own situation. 1 to 2, you can easily forget it, psychologically speaking.
Sure, you agree. So, did you compare pedicle ontoplasty and toe transfer on ontoplasty? You tried to do that, Stephen, but we have so a limited number of patients with ontoplasty, so it's difficult to compare the result between toe transfer. I mean, it's short series.
It's another indication for some reconstruction and constriction band syndrome. I think it's clear that toe transfer is the best solution for that. And only if you have these cases where the feet are totally shortened, then some other solution should be found. And I think this transposition ontoplasty is better than a distraction lengthening, because there are some joints in, also passively mobile one.
It depends very much, I think, Wiebke, you're right. I think it depends very much on the soft tissue distal. If soft tissue distal is very tight, then you cannot do an ontoplasty there, and you need extra soft tissue to go there. Shorten it maybe to get the on top better on, as we've seen in radial polydactyly sometimes. If your pedicle is very nice, then you won't get very much cold intolerance. But if you have a very thin on top, I'm afraid, at least in Holland, for cold intolerance, and in the northern Germany also.
We have the result of some polls, and my question was, have you ever performed an ontoplasty? And few people, 59% said yes, but 41% never experienced that procedure. It's still a very rare indication. I mean, but that's why it was interesting to discuss on the webinar. Yeah.
In post-trauma, I've done it a couple of cases. Same like Wiebke shown for the constriction ring, but it's mostly you go to toe transfer or thumb lengthening in those cases.
And we had an answer, did these presentations inspire you with new indication for finger reconstruction? 95% said yes. So we
super.
inspired people. So
Super.
it's
Nice.
happy to be helpful.
Is that for the thumb reconstruction only?
We have two questions and then we can finish. Just a question for Wipke. Do you use K-wire for fixation? Yes. And what about growth plate injury?
Because of the K-wire?
Yeah.
No. Also, if you leave it for 1 year, yes. But only for after 4 or 6 weeks, I can no. Very single cases, no. We use K-wires normally, yeah. We like K-wires.
Of course, not big K-wires.
You know, 0.8 or in bigger ones, 1.0 millimeters. Yeah.
The only remark I would like to make, I use K-wires also, but the only remark I would like to make is try to avoid it. For post-operative care, it's easier. You don't get infections. You don't get many infections, but still, one infection is enough for a thumb like that. And the other part is I've seen one case of a fusion alongside the K-wire, with only 4 weeks already. And which is actually funny to see. It's only one case, but in all those years. But it made me also think: should I have used a K-wire there? Yes or no?
I remember Dieter Gramko said he never had any epiphysiodesis with a K-wire in his whole
Also,
series.
we should go through the amount of 1,000 patients to look after. Also, that would be interesting. Nobody has done it, despite K-wires are used so often. That would be interesting to do that.
But let me ask you, Wipke, if you think of all your K-wires, could you have prevented quite a few K-wires?
Yes, for example, for toe transfers, if we do we do a arthrodesis, also put it at the metacarpal level, we use PDS 4 PDS sutures, for example.
Yeah,
that's fine. It's
Yeah,
a 3-year-old, no? They're normally 3 years old.
And what about you, Stéphane?
Sorry, because I'm looking for the chat, so I haven't any comment for that.
We are just chit-chatting a bit about K-wires and about alternative methods.
I never had any problems, never experienced any epiphysiodesis, and infection are really, really rare. The problem is when the K-wire are thrown away by the child or by the nurse during the new bandage, and that's a problem, an issue, because you have a very instability and you can have some problem when you transfer, for example, a non-vascularized toe phalanx. If your K-wire is removed before 3 weeks, I have seen some resorption of the...
Yeah. Because we've all worked in surroundings where patients can be far away.
Yeah, that's an issue.
It's missed, and which makes it a little bit, sometimes also, sometimes I find it a bit scary, so I would rather if I can, do it without.
A question from Diana Middleton. During the clinical assessment, do you want stability or mobility? I mean, I want both. but I mean, a stable finger is more functional than an unstable, of course, even if it's stiff. But
if you want a gunshot choice, I would take stability proximal and movement distal. But of course, you're right. You'd rather have both. Yeah.
Okay. So maybe we have finished with this webinar. I would like to thank you for your presentation, for the discussion, and also the audience. Also, we will have some different webinars in the future. Caroline Leclerc said that the next one will be on by Mr. MATHOULIN on the wrist, and also one webinar will be on the elbow with VIDIL. So thank you again for your participation, and I hope to see you not virtually but physically in the future. Thank you again.
You're welcome. Bye bye.
Merci bien.